This case we will discuss as a short case. You can give a very brief history and very only the relevant general examination findings, and then you can straight away go for system examination. You can first give the final diagnosis, and then you can go for the presentation.
A case of cyanotic heart disease, most probable tetralogy of Fallot.
It would be better to put it as congenital cyanotic rather than just cyanotic.
4-year-old male child, second born of non-consanguineous parents, informant mother. Child was apparently normal till 3 years of age. History of fast breathing on running or playing since 3 years of age. Relieved on sitting. The child was screened in the school by a doctor and was referred to medical college for further evaluation, suspecting a heart disease.
Although the mother is saying that the child gets relief with sitting, now that we know the diagnosis as DOF, the history must be elicited in such a way to confirm whether it was actually squatting or not.
Past history. During the neonatal period at 12 day of life, the child was supposed to have some heart disease and was referred for evaluation, but parents were reluctant as child had no symptoms. Antenatal.
You can skip that slide.
Development. Normal. He goes to school, now in UKG. The child has a deficit of 610 calorie deficit and the proteins are normal.
Can you give your impression on anthropometry here?
Anthropometry. Height and weight between 10th and 25th centile.
His growth failure at least partially can be explained by his dietary inadequacy. So growth failure need not be because of just the heart disease that he is having.
Immunization. As per national immunization schedule, vaccinations have been taken, no additional vaccinations taken. Family history, second.
There is a very long gap between two children in this case. So you may ask for a possible reason, for example, recurrent abortion.
Socioeconomic status, the child.
You can skip that also.
In short, 4-year-old male, developmentally normal child, second born of non-consanguineous parents with episodes of fast breathing associated with exertion. Grade 2 NYHA, squatting episodes to relieve the breathlessness, with no history of recurrent chest infections and slow to gain weight.
From the natural history, it looks like the child was a pink fallow to start with and then progressed to classical fallow.
Now we come to the examination. Child was comfortable and alert, no pallor, not icteric, central cyanosis present, and grade 2 clubbing was noticed. Vitals, saturation maintained at 88% in room air in all 4 limbs. One
question that may be asked is whether you will give oxygen on seeing this saturation of 88%. Actually, oxygen will not increase saturation in cyanotic heart disease because it is actually mixing. And in TOF, 88 is a very decent saturation. Usually it will be much less than that.
Coming to the CVS examination, on inspection, no abnormality detected, no precordial bulge, pulsations or dilated veins. Palpation, apical impulse of normal feel and felt in the left intercostal space in the midclavicular line, no parasternal heave or no palpable thrill present.
Agreed. Although textbook may say that apex will be right ventricular, many a time on clinical examination it may feel normal. So your finding is accepted. And you can also mention JVP is normal. We do not expect a raised JVP in an uncomplicated TOF. For example, if there is cardiac failure following infective endocarditis, yes, you can have raised JVP.
Auscultation, mitral and tricuspid areas S1 and S2 normally heard. Pulmonary area, single S2. A 3/6 ejection systolic murmur is heard in the second and the third intercostal space along with the left sternal border. There is no radiation anywhere including back. Aortic area normal, no other murmur in the precordium and the back.
Here, you may pause the video and note down all the clinical, both inspection, palpation, and auscultatory findings. It's called tetralogy. So, what are the 4 components of tetralogy?
Non-restrictive subaortic malaligned VST, right ventricular outflow tract obstruction, right ventricular hypertrophy, overriding of aorta, that is aorta overrides the ventricular septal defect. In 25% of cases, there may be right aortic arch.
The right aortic arch is detected by the indentation that it makes on the right side of the tracheal air shadow in X-ray. I shall explain it using a X-ray that I have taken from radiology masterclass from the internet. On your right side, you will see the X-ray without marking, and on your left side with markings. Normal position and the position and the indentation that the right aortic arch makes. Tell us about the collaterals.
Bronchial collaterals arising from a normally existing bronchial arteries anastomosing with pulmonary arteries from aortic branches like internal mammary, intercostal, subclavian, etc. Usually made out clinically by continuous member in the interscapular areas.
Heard of pentalogy?
Pentology is an addition ASD as a fifth component of tetralogy, thus making it a pentology.
This child was not cyanosed at birth, but cyanosed later on. So, what could be the reasons for delayed appearance of cyanosis?
Appearance of cyanosis in TOF is delayed up to 3 to 6 months. The proposed reasons are: number 1, increased activity as the child grows; number 2, closure of PDA; number 3, progressive infundibular stenosis due to hypertrophy of infundibular muscle. The proportion of fetal hemoglobin comes down. Fetal hemoglobin has more oxygen binding capacity. More than 2/3 will have cyanosis by 1 year. Remaining will develop cyanosis soon in toddler period.
What are the reasons for continuous murmur in EOF?
1. PDA. 2. Collaterals. Bronchial collaterals relatively silent. 3. VT shunt.
What are the drugs that you must avoid in POF?
1. Vasodilators, and 2. Those causing tachycardia.
What are the complications of POF?
Complications of TOF are: most common is cyanotic spell, commonest age is 2 months to 2 years, growth retardation, polycythemia, brain abscess, thrombosis, infective endocarditis, usually pulmonary where rarely tricuspid, iron deficiency, anemia, bleeding, and aortic regurgitation.
Is it possible that POF may develop aortic regurgitation? And if so, why?
Aortic regurgitation could develop due to endocarditis, progressive dilation of aorta, post-surgical due to stitching inadvertently going through valve clasp.
Tell us about BT shunt.
It's usually between right subclavian and pulmonary artery. Usually a graft is also used when it's called modified BT shunt. Radial pulse of same side will weak as blood gets shunted to pulmonary artery, and there will be a continuous murmur at the second space.
Do you know any syndromes associated with POF?
It can be associated with DiGeorge syndrome, where part of chromosome 22 is deleted, Catch-22, where there is deletion of short arm of chromosome 22, fetal alcohol syndrome, and fetal warfarin syndromes.
The pulmonary obstruction, is it always infundibular or other types are also possible?
50% is infundibular stenosis. There can be infundibular plus valvular and pure valvular. Rarely, total atretic pulmonary valve, that is pulmonary atresia, is seen.
What are your differential diagnoses?
Double outlet right ventricular with VSD and pulmonary stenosis. Single ventricle with pulmonary stenosis. Transposition of great arteries with ventricular septal defect and pulmonary stenosis.
When is the total repair, at which age the total repair of POF is undertaken? Tell us about the X-ray and ECG findings in POF. Before we wind up, I shall try to explain why there is a constellation of all these 4 findings in tetralogy. Assume this is a normal heart. This is the ventricular septum. And from left ventricle, the blood goes to the aorta. From the right ventricle, it goes to the pulmonary. Suppose the part of the upper part of septum displaces itself in an anterior encephaloid direction this way. Suppose it is going this way. It will press the pulmonary. So the infundibulum will be pressed. And because this is going this way, there will be a big ventricular septal defect. So much so, there is a ventricular septal defect and a compression of infundibulum because this part of the septum got displaced cephaloid and anterior. This is a picture after the septum got displaced. Now the pulmonary has become smaller. Aorta actually has become bigger because along with the shifting of this septum, it has drawn the aorta along with. So much so, it the aorta now overrides this, can receive blood from both right ventricle and left ventricle. In fact, because there is a stenosis here, right ventricle finds it easy to push the blood to aorta rather than to the pulmonary. So there is right to left shunt. So hence the constellation of all these findings, that is pulmonary infundibulary stenosis, a big VSD, and because there is a pulmonary stenosis, there is right ventricular hypertension. And because the septum draws aorta along with it, the aorta now is placed above the ventricular septal defect. So much so, it can receive blood both from right ventricle and left ventricle direct. That is called override.